So let me tell you a little bit about the presenter that we have on tonight. You guys are in for a treat because our CEO and President, Leslie Stevens, is actually with us tonight. As I mentioned, Leslie is a wealth of information. She is the CEO of HealthyStart, but she's also a mother of 3. And her goal and desire is to provide every advantage for children to allow them to live healthy and happy lives. You know, I'm not sure if you're aware, but there actually is a silent epidemic affecting 9 out of 10 children. And this epidemic manifests itself in a variety of symptoms that can be easily overlooked, misdiagnosed, and most unfortunately left untreated. It's critical that children are evaluated for sleep and breathing habits. Leslie is not only our fearless leader, she actually lectures and trains all over the world. I don't think there's a question in reference to the subject of pediatric sleep, breathing, and airway and Healthy Start's connection that she cannot answer. And really, when you have the backing of a company like Healthy Start for Orthotain, you have 51 years, over 4 million cases, and tons of research to back you. Leslie's mission is to educate both parents and oral physicians to ensure children a lifetime of health, happiness, and success. So I'm actually going to take this time to hand the floor and the mic over to Leslie Stevens.
Well, thank you so much, Susie. This is obviously a great Thursday. I always love doing these medical webinars, and I look forward to spending a few minutes with all of you and going through what is going to be hopefully one of the most educational 45 minutes of your life. So we've been working on children's health for many, many years, and each and every day I wake up with the same mission in life, and I find it just amazing that we're at this point in time where not only has the ADA recognized this area, that now this has come into the forefront. Pediatric sleep, breathing, and airway issues is currently the #1 topic in dentistry. And I am thrilled that you all are taking time out of your evening to spend a few minutes with us and let us give you a little overview of what this is all about, how we identify it, how do you evaluate it, but most importantly, how can I help my patients in my practice? How can I make my practice grow? How can I educate the community so that parents understand what I am doing in my practice, and obviously changing each and every child's life? So without any further, let's kind of get going, and I would love to answer any and all of your questions, so please don't hesitate to put them up, and we will address them and make a wonderful evening of this. So as I said before, what is a wonderful attribute and really basically a wonderful comment on the ADA is that they are trying to take the lead in this discussion and really put dentistry in the forefront of this. So many times I say that you're no longer a dentist, you're really an oral physician, because you are the knowledgeable body that really can look and address and understand what's going on in the oral cavity that affects so much more than just the cosmetics of what we see in dentitions. So the ADA last October, October of 2017, actually proposed a policy that would require each and every dentist to identify sleep, breathing, and airway issues in their patients, improper growth and development, and be responsible for educating themselves in this arena. So you're starting on your journey. Hopefully this is the first of many courses that you will take, and the beginning of what I hope to be something that changes your practice. So when we talk about sleep, breathing, and airway issues, we basically, as dentists, are going to look at the underlying root symptoms that contribute and portray other issues that are happening. So these outward symptoms include mouth breathing and snoring and teeth grinding and swollen adenoids and tonsils, chronic allergies, eczema, asthma, ADD, ADHD, aggressive behavior, depression, irritability, anger, pair problems, few friends, bedwetting, difficulty in school, especially in subjects of math, science, and spelling. delayed or stunted growth, restless sleep, nightmares, morning headaches, daytime drowsiness, frequently wakes up at night, sleep talking and walking. And what these outward symptoms represent is a huge majority of these children. We see that 9 out of 10 children have one or more of these outward symptoms. And what is so critical is that we look at sometimes, unfortunately, each one of these outward symptoms as isolated conditions. For instance, asthma. So often a parent goes and sees an asthma specialist and their child is prescribed steroids or whatever to help them with that condition. Well, that child might also have asthma. They might also have allergies. They might have ADD and ADHD. And what the conversation tonight is looking at these outward symptoms and using them as screening devices, because this indicates that there probably is a more serious underlying root cause, that these outward symptoms are basically linked to the same or many a few underlying root causes. So the importance is look at what you have to identify, be able to understand that there might be a link between them, and then obviously screen for these kids. Now, typically, what a parent that looks at an outward symptoms, and as we have just said, they look at them in isolation. So, what are parents doing? We talk about medication. They're looking at prescription drugs. They're looking at psychiatric testing, counseling, therapy, surgery, sleep study test, allergy testing, special education, tutoring, diet changes, rapid palatal expanders. These are all different tools that are used to identify and address individual outward symptoms. And tonight, I would like you to take a step back and realize that many of these outward symptoms are linked together. And they're linked together because they all represent an outward symptom of an underlying root cause. So typically, or so frequently, addressing these in isolation and looking at these drugs and these other are basically addressing only the outward symptoms and not the root cause. These prescriptions or different medications just tend to be short-term band-aids. Many times the treatment involves several drugs with many side effects. And unfortunately, many of these are costly, painful, time-consuming, and most unfortunately, ineffective. So if we can just take a step back and basically look at the underlying root causes and look at these symptoms and address those prior to us looking to any other kind of other means like drugs or um, uh, prescription drugs or different medications that can help. Let's see if we can address the underlying root causes. So you as a dentist are in the ability to basically address these. And research over the past 20 years has linked these outward symptoms to root causes such as mouth breathing, narrow palate, improper tongue placement, and jaw relations. So, how do we as dental professionals screen for sleep? As we have discussed, the situation is interesting because it does offer you the ability to basically um, collaborate and collaborate with the medical professions. Because as you know, as a dentist, you are not allowed to diagnose sleep apnea. You are allowed to screen for it and you're allowed to treat it, but you're not allowed to diagnose it. And this, you can look at it as the glass half full or the glass half empty. But to be realistic, it might present a wonderful opportunity to collaborate with other medical professions or professionals. We have been very fortunate to collaborate with pediatricians and ENTs and pulmonologists, sleep specialists, because this is the area that each of us represent an expertise in a certain area of this discussion. And if we can collaborate together, we can basically address these children in the most comprehensive way. So you as a dental professional will be screening for sleep issues. So how do we screen for them? Well, the first thing is let's look at visual cues that we have from kids. You can pick up so much by just looking at a child. So let's take a look at the girl on the left. What do we notice first off? Look at those dark circles under their eyes. Look how her head is perched forward. Look at the boy on the right. Are the lips parted? Is he probably mouth breathing? Look at the circles under his eyes. Look at just basically the outward structure of his face. He looks like he's a relatively heavy boy. He's not. But the way his face, his lower third of his face is configured, it makes him look like he is heavier than he really is. Let's take a look at the profile of a patient. Look at this girl right here. What do we notice? Deficiency in the lower third, especially in the mandible. Are her lips parted? Look at this rolled lip that we have here. Is that lip actually preventing that lower chin from moving forward? Absolutely. It's interfering. It's causing a blockage because it is basically caught under her upward dentition. Let's look at the girl on the right. Same deal. Look at how deficient she is in the lower third, especially in the mandible. Look how the mandible, the chin basically blends right into the neck. There's no definition. We again have that rolled lip. We'll talk about it a little bit later, what we would anticipate seeing when we see a rolled lip in a profile, especially a overjet and possibly even an overbite. You can see the circles in the eyes as well. So right off the bat, you've probably picked up about 4 or 5 different clues that might make you suspect there is something going on. And remember, 9 out of 10 children are going to basically exhibit one or more outward symptoms. So the probability that there is something there is probably much greater than you ever realized before. So what can we use as a great screening tool? This sleep questionnaire that HealthyStart has developed is an excellent tool, and it's excellent for certain reasons. One, it represents the 27 most frequent outward symptoms of sleep, plus a speech questionnaire. Many times, if a child's tongue is not in the right position, nor has the proper swallow, or has basically the lack of function of the tongue, pronunciation is going to be difficult and speech is going to be complicated. So we see a lot of speech issues in these children when we look at them. But another area that makes this very unique is that the sleep questionnaire is going to basically rank the severity of each symptom. So we're going to rank them from a 0 to 5, 5 being the most pronounced. And this will occur in the initial portion of the questions, of the 27 questions. Now, typically we ask a parent to fill this out. If it's going to be a mom, we ask that throughout the scheme of treatment, we want that same parent to be filling out the sleep questionnaire. So we basically are assured more consistency in the scale that is being used. HealthyStart conducted a research project that was done on over 500 patients. And basically these patients were children that parents filled out a sleep questionnaire to determine what kind of symptoms do we most frequently see associated with sleep, breathing, and airway issues. So the results of this study basically said that mouth breathing and snoring are commonly associated with more sleep disorder breathing symptoms than any other symptom study. I want to make a special note that snoring is, I don't care for the word because snoring conjures up all different kinds of symptoms. We all associate maybe the word snoring with our grandpa basically taking the shutters off the house, that loud noise that occurs. Well, in a child, it's really audible breathing. If you're in a room while your child's sleeping and you can hear them breathe, they have a mouth breathing issue. So that's kind of the word snoring. I would really associate it with audible breathing. The study also portrayed that 9 out of 10 children had one or more outward symptoms of sleep. 60% of the sample had 4 or more symptoms. 1 out of 5 children experienced bedwetting, which is very interesting. I don't think any of us realize that it's 18.6% of the kids will bedwet at a later age. Interesting statistic. So to put it in perspective, if you have a classroom of 20 kids, you would anticipate 4 of those kids to be bedwetters. How often, even as a child, did you remember the child that the mother would never let to go on a sleepover? Or the child that always wasn't going to camp, or had different reasons why the sleepover didn't occur. Imagine how many kids this really represents. So I was quite shocked after this research occurred at how frequently um, the condition of bedwetting at a later age occurs. And the last point, and I'll make it s- emphasize how important this statistic is, that between 4 and 12 years of age, 92.6% of the outward symptoms did not self correct, while 30% worsened with age. I would basically tell you, if you see it, treat it. Majority of the cases will not self correct. Make that child's life healthier by addressing it early on rather than waiting later until that habit is more ingrained and the orthodontic condition and the other areas of concern or underlying root causes become more difficult to correct. So when we talk about mouth breathing, that is probably the number one. You'll see it's about 43% of the testing population had a mouth breathing condition. What's interesting is if you mouth breathe, that means if you open the mouth just by a half an inch, it means you're going to reduce your airway by 6 millimeters. Well, unfortunately, a 7-year-old only has an airway that's 7 millimeters in diameter. So, what does that mean? That means that child is trying to breathe through 1 millimeter of airway each and every night. Can they get enough oxygen? No. Are they getting into REM sleep? Probably not. These are the areas that cause concern because it is going to put the body into an unbalanced situation, meaning that it is going to affect the child in the neurological, the endocrine, the immune, the hormonal. Basically, that child's going to experience all sorts of outward symptoms because they're not getting enough oxygen. So you can kind of see where our conversation is going and why those outward symptoms are such amazing clues for us to be able to further investigate that child and the development that's occurring and the underlying root causes that could be um, apparent. If a child mouth breathes during the day, we expect to see 8 other outward symptoms. If they only mouth breathe at night, we see basically 7 other outward symptoms. And here are some of the other symptoms that we see associated with children with mouth breathing. So the implications of this study basically find that sleep disorder breathing is much more common and it affects children as young as 2 years of age. Um, I would actually pose to say we actually now can see sleep issues in children that are even in the before they're born. If a mother has a sleep issue, less oxygen is getting to the fetus. We also see children that can also start sucking their thumb even in the womb. So we will see a lot of these issues already starting even before a child's born. We begin treatment as early as possible to ensure more permanent changes. And by identifying outward symptoms displayed in 90% of the children that enter your practice, can significantly reduce this epidemic and enable you to successfully treat the overall health of your patients. Do you realize that 9 out of 10 children in the United States representing this epidemic basically constitutes 40 million children? 40 million children. That is an epidemic. And that is what hopefully tonight will start your journey to start identifying, evaluating, and most importantly, treating these kids. So let's talk about airway. How do we address airway? What are we looking at? How do we educate a parent? Why is airway important? So, an airway, every parent says, well, of course my child has an airway. How else would they be able to breathe? Well, that's true. But what is the size of that airway? How much oxygen can get through that airway? Is that airway compromised? Is it restricted? What are the implications of having a restricted airway? So, as we talked about before, just by mouth breathing, a 7-year-old who has a 7 millimeter airway can reduce his airway to 1 millimeter. What does 1 millimeter really look like? A good visual is to compare it to a coffee stirrer. If you look at this coffee stirrer, this represents about a millimeter airway. I don't know if you've ever tried to breathe through a coffee stirrer, but I tried. I mean, I wear every appliance. I want to make sure I know exactly what it feels like. If a child is talking to me, I can talk the same lingo they do. So, really, to be on the same page as a parent, I wanted to experience what breathing through 1 millimeter felt like. So, one day I decided I was going to try to breathe the whole day through a coffee stirrer. Well, let me tell you, I got through about 10 to 15 minutes. And after that, I couldn't do it anymore. I had the most massive headache I've ever had. I could get rid of it. I took Excedrin, nothing helped. I finally, the next morning after I went to sleep, woke up the next morning was the only time my headache ended. So give it a try. Tell me how you experience. But all I could think about was, oh my gosh, what a struggle that would be for a child who has not the ability to explain what's going on because they don't know what normal is. This is how they feel life is. And they can't explain to a parent how difficult this is for them. And the only thing they can show us is their outward symptoms. And, as a parent, if you don't know, you don't know. So that's why this education is so important. So, how do we explain what an airway should look like to a parent? Well, maybe compare it to a garden hose. That's what we're looking for. We want to create an airway that resembles a garden hose. So, how is this happening? Why is this happening? Why do we see these numbers escalating each and every generation? Well, it's coming. It's been developing for a long time. Let's look at what our society now has introduced to the infant population. We tend to see a prolonged use of pacifiers. We see an increased use of nipple bottles, less breastfeeding, soft diets. So what does that really mean? Tell me exactly what you're talking about. Well, let's think about a pacifier, a bottle. The way the nipple is designed, it depresses the tongue. And when it depresses the tongue, it basically prevents it from being in the upper palate where it belongs in order to encourage the nasal breathing. By putting the tongue in the upper palate, we're going to start developing the upper arch. We're going to create the space for the tongue to be at. We're going to basically increase the nasal capability of them to breathe in a proper way. If we have a soft diet, the soft diet is not using our occlusion to basically develop the arches. So we see collapsed arches. A bottle or pacifier also creates a suction in the mouth, and that suction basically collapses the arch. So now all of a sudden the arch is collapsing. It's creating a narrower arch. The tongue can no longer fit itself up in the palate, so it's laying low. If it's laying low, it's not being used functionally. Is it losing its tone? Absolutely. What do? We tend to open our mouth and we start breathing through our mouth. Are we going to affect the way our oral cavity is developing? Absolutely. So, how do we? We have to create a way that reverses what's going on and does what nature should have provided for each and every kid. So, when we look at a child, if we see a child with an open bite like this, already we should realize in our head, probably a result of pacifier and prolonged nipple bottle, maybe even a finger sucker, and obviously probably a tongue thruster. And we would assume a mouth breather. So these are the kind of conditions and the outward symptoms we're thinking about when we see a child's occlusion. We talk about airway, so it's important to explain to a parent what that looks like, where the nasal cavity is, hard palate meets soft palate, where the position of the tongue, look at the airway. These are all important parts of anatomy that a parent might be interested in knowing. But we need to really focus on the importance of the nose. Why is nasal breathing so important? Well, the nose has basically 5 functions. It serves as an air passageway. It warms and moistens inhaled air. Its membrane taps dust, pollen, bacteria, and other foreign matter. It contains receptors which sort out odors. It aids in pronunciation and the quality of the voice. So these are really important aspects. I often hear, oh, you know what, the tongue's too big for the child's mouth. Well, What's happening is the arch is too small, and the arch needs to be expanded in order to accommodate the tongue in majority of the cases. So always realize if you see something that doesn't look normal in development, there's usually a byproduct or an underlying reason. And that's kind of what this is all about. How often do we see kids in a car seats, sleeping, mouth open? We know that 43% of the cases, again, will be a mouth breather. This is a really important little video I want you to watch so you can see how mouth breathing affects a child. And I'm sure you've all seen an Eli in your lifetime. So let's take a listen.
Now he's holding it. That was holding it. He's still holding it. He's trying to take in air. There he goes. Now watch. He's holding it. He's holding it. He's holding it. He's holding it. He's still holding his breath, and now he's going to gulp again. There he goes. That was it again. And again. He's holding. He's holding. He's trying. There he goes. So this has been 3 minutes and 15 seconds, and you can see how many episodes he's had of not getting calm breaths in. Now watch what happens when I take his jaw. I just bring it forward. I can. Let's see if I can. And I open his airway. Just bring his airway forward. Now listen to the quiet breathing. There we go. Now he's breathing through his nose. And I brought his airway. I'm opening his airway. Pulling his jaw forward ever so slightly. And now he's breathing through his nose quietly. His mouth is a little bit open, but he's breathing through his nose. Just by hear how quietly he's breathing, you don't hear him anymore. And all I did is gently bring his jaw forward.
How amazing is that? Look at just by bringing the lower jaw forward or preventing the lower jaw from drifting back because of mouth breathing. Look how silently that child sleeps. You can see it on his facial structure. You can just feel the ability for him to relax and to get the reparative sleep he needs. So Healthy Start is basically going to provide the mechanisms in order to make this occur for a child. It's going to eliminate the mouth breathing. It's going to basically allow the lower jaw to be developed in a forward direction. Sometimes the maxilla also needs to be developed. It will be able to do that as well. It's going to prevent the mouth breathing and allowing the lower chin to drift back and basically eliminate part of the airway. It's going to position the tongue in the upper palate of the mouth. And it's going to promote the proper breathing as well and swallow. So this is all that can occur with the Healthy Start. And this is why we create that kind of mechanism so that we can basically ensure a child to be able to breathe, sleep, and develop an airway in a permanent fashion for the rest of their life. So again, let's remember, part of the study that we conducted also indicated that if you see this, you treat this. You don't let it go. We're not going to wait until 10 years from now to see if it will self-correct. 92.6% of the cases, it is not going to self-correct. And as I said, 30% will even worsen. So this is a bad problem. This needs to be identified. And you, as the oral physicians in dentistry, are the ones that can make this happen. So we talk about airway. So let's again talk in dental terms. Let's take a look at Seth. what is a restricted airway? What is a normal airway? So the child on the right, obviously we see a normal airway. The child on the left, we see a restricted airway. We already know by taking an image, whether it's a CBCT scan or a Ceph, is we know that 21% of the cases will have a restricted airway. We have to realize that these are the tools that we have available to us. Are they perfect? No. Are they the best we have? Yes. What makes them imperfect? Well, we're taking an image in a vertical position. We're not taking an image in a horizontal when the child's sleeping. Will when they sleep, will it be worse? Absolutely, because the muscles relax. And when they relax, the airway is closed even further. So we already anticipate if we have a constricted airway in a vertical position, obviously it probably worsens as the child sleeps at night. So we had talked about maybe we see a child that has a normal airway. We took a Ceph, we took a CBCT scan. It looks pretty normal. They have a pretty wide open airway, but they still have all these outward symptoms. What is happening? Well, we know that the balance of those kids that don't have a constricted airway basically have a habitual problem. And that could be mouth breathing being the number one. So again, as we said, when they open their mouth, we can restrict the airway up to 6 millimeters. And this diagram here on the right basically shows how that restriction occurs. So we talked about the coffee stirrer versus the garden hose. So what does that exactly mean? Here's another image. So on the right, we talk about an ideal airway. 100% airflow in a 7-year-old. They have a 7 millimeter diameter of an airway. That's exactly what that looks like. Now, remember I told you if you mouth breathe, you take away 6 millimeters and it leaves you with 1 millimeter? Well, look all the way down to the left. That's 1 millimeter airway. I don't know about you, but how the heck would you get enough oxygen? It's like a pinhole. And they basically have 11% airflow. Are they getting a good night's sleep? Are they getting enough oxygen to get into REM sleep? Probably not. So this is the conversation we're having. And you'll see these in our brochures so that parents can see them and identify with them. Here's a very interesting case. Another way of how we anticipate what is a normal airway. Do we have a legitimate evaluation or number that we could categorize a normal airway? Well, yeah, they've come up with something. And what they have determined is we take the age of the child starting at 5, multiply it by 10. So for instance, if we have a 9-year-old, we would anticipate to see a normal airway of a 9-year-old as 9 times 10 equals 90 square millimeters. Well, this child here on the left is a 9-year-old. Unfortunately, has an airway of 53.6 square millimeters. We would anticipate 9 times 10, a 90 square millimeter. So he's deficient. So we're going to start with the first appliance in the HealthyStart system, which is called the habit corrector. And we're going to have them wear it. Now, this patient actually wore it for 1 month, is still in the process of treatment. And we wanted to see what type of gain of airway are we getting while the appliance is in the mouth at night when they sleep. So looking at this in a vertical position, we found that that airway is at 337 square millimeters. Well, wow, that's 6 times greater than what it was a month ago. Now, what here is the interesting part. In a normal development of an adult, we anticipate the airway to grow to age 17. And at that point, we reach our kind of our maximum, which is between 150 and 170 square millimeters. Bad news. At age 21, our airway starts to deteriorate over the course of our life. So we see all these adult patients that are walking around with sleep apnea. So the question has always been, did they reach their potential and now they're compromised? Or maybe is that normal that we look at for between 150 and 170 not enough airway to last us for the rest of our lives? That answer hasn't been answered yet, but hopefully soon. But look at this. We're able to basically get a 337 square millimeters in this case, which is more than double what we anticipate in adult. Now, we're in the process of a few studies going on looking at this exact scenario and basically determining what is the stability of the airway over the course of time. Well, my guess is, if you're at 337 square millimeters, what do I care if we deteriorate a little bit over the course of time? We got a long ways to go to even remotely come close to what we anticipate as our current goal of 150 to 170. So these are the questions we're asking, and this is what we're heading toward. So we can basically provide even something greater than what we would anticipate that myself as a parent, or maybe you as a parent, would anticipate over our lifetime, but maybe we could provide this for our children, or maybe in my case, grandchildren, whichever it might be. So anyways, here's a little schematic of what we see. So it was 54 square millimeters. We would anticipate 90 square millimeters. And this is what we ended up in the first month of progress. So kind of an interesting scenario. So let's kind of recap what we've talked about. We know that mouth breathing and snoring are probably the #1 outward symptoms and conditions that we need to be concerned with. And this would represent basically probably a result of extended bottle feeding and pacifier use, poor tongue position and abnormal swallowing, possibly affected by a poor diet and encouraging more sugar and processed foods, and maybe having poor oral habits, thumb sucking, finger sucking, tongue thrust, things like that. Well, these conditions and the mouth breathing basically create a compromised airway. And what happens with a compromised airway? Well, obviously we're going to reduce the airway, restrict airflow, reduce oxygen, increase CO2, affect brain function, immune, endocrine, and even hormonal functions, create swollen adenoids and tonsils, low tongue position, tongue thrust, underdeveloped dental arches, encouraging overbite, overjet, open bite, and also cross bites. So the compromised airway basically creates these outward symptoms of sleep disorder breathing. And these outward symptoms, again, just some of them: restless sleep, ADD, ADHD, bedwetting, chronic allergies, nightmares, the list goes on. This goes back to our sleep questionnaire that basically looks at those 27 outward symptoms. So an interesting study that occurred. So let's see what this really means. How is it affecting the neurological behavior? Well, here was an interesting study that looked at MRIs of individuals that had a full night normal sleep. And this would be the first 3 top screens. And you can see the normal brain function that is occurring. Look at the lower 3 slides. Now, this is brain function after 1 night of sleep deprivation. You're going to really look hard for any brain activity. Look at here. So you can see the dramatic effect that a lack of sleep has on the brain function. Okay, so let's talk about HealthyStart. Fortunately, Orthotane, who is the parent company of HealthyStart, has been around 51 plus years. And to date, we have treated over 4 million kids. So we've been around, we've treated a lot of children, and we're always pushing the envelope for more and more and newer technology. We are the leaders in this industry. We are the developers, we're the creators, we hold the patents. We're basically work very, very hard, and we have spent many years understanding growth and development in the pediatric patient, and understanding how we can almost predict that growth, and understanding what the development of the oral cavity means, both in dental and, more importantly, in health issues. So the HealthyStart system basically has 2 to 3 appliances that are used on each age patient. The first appliance is typically a habit corrector, and it is exactly what it says. We're going to deal with the habits of the child. And with this, we're going to show you how the myofunctional therapy is built into each and every one of these appliances. So simply by wearing it at night when the child sleeps, we're going to make sure that with every swallow, that myofunctional therapy is occurring. So how great is that? I mean, when they're sleeping, we're actually promoting the proper growth and development. We're preventing those poor habits from occurring. And more importantly, we're creating the proper swallow, the proper breathing, all just with a good nighttime wear. Now, if you have a child that walks in who might be age 5, the process would basically be under the HealthyStart Kids system. We would start with the first appliance being the habit corrector. As soon as the first permanent tooth starts to erupt, we would move into the second appliance called the HealthyStart C series. And this is going to actually guide the incoming teeth. And as it's guiding, it's allowing the tooth to come in straight. If it's rotated, the appliance is going to capture it, allow it to erupt, but it's going to put natural pressure on the adjacent teeth. So we're going to start expanding the arches. We're going to create that arch development that we would anticipate in a normal growth and development. And we're using the eruption of teeth to accomplish this. We're also allowing the teeth to develop into a straight position and allowing the fiber bundles that anchor the teeth to basically stabilize the case, but also become the retainer for the rest of their life. The teeth grew in straight. They know no other position. There is a very low percentage of relapse that occur in these cases because of that. At the same time, the appliance is designed to correct any overbite, open bite, crossbite, overjet, class 3, deficiency in both the upper and lower, gummy smile, all of this, primarily just with nighttime wear. Now, the third and final appliance will basically be given as the laterals start to erupt, because now the child's moved from primarily primary dentition to a mixed dentition. And this is the appliance they'll wear basically during the development, and will carry them through the entire treatment. Now, if we look at teens and adults, we've been talking primarily of children, but we do treat adults. Our oldest patient is actually 84 years old. And it's the same process except one slight change, and that is there's no more growth and development. With growth and development, we can do so much more because we're promoting the growth. We actually get 54% more growth in the lower jaw than in a control sample. So we can actually predict how much growth we can gain using these appliances. When we're working with adults, there is no more growth, or we can make more minimal changes. So we have to make sure our guidelines are appropriate. But addressing and looking at habits can happen in any time in your life. The problem is sometimes our habits are more ingrained in an adult patient. So it might not be something that we can permanently change. It might be something that a patient would have to wear this every night. Simply very similar to what a retainer is after orthodontics. But that is only in the adult appliance or adult patient because of the lack of growth. So let's kind of review. HealthyStart addresses the root causes. And how do they do that? Well, we do it by expanding the dental arches, establishing nasal breathing, training the tongue, eliminating bad habits, advancing the mandible to correct overjet, encouraging proper facial and body growth, since lack of REM sleep impairs function of adrenal glands to secrete growth hormones, and correct most orthodontic problems. And this is, again, ideal overbite and overjet, proper intercuspation of dentition, molar relations to a class 1. We provide fiber development on straight teeth for stability. We reduce or eliminate future relapse due to proper alignment before adult collagenous fibers form. And we reduce the chance for orthodontic treatment later. So let's talk and look at exactly what is built into the habit corrector and what each one of these appliances can provide. So when we look at the habit corrector, and they come in a variety of sizes, there's actually 4 sizes, toddler 2 to 4, kids 5 to 7, preteen 8 to 12, and then adult, which is 12 and above. So when we look at this, it has this myofunctional capability built into each appliance. So we look at these vertical tabs, which are actually expansion tabs. So the tongue is pressed against these tabs to actually create the expansion and create the room for the tongue for placement. We also see that we can add pads to the appliance, and if the pads are added, it's basically to help close the open bite case. We have a ramp or a lingual shelf, and it's on a ramp. So every time the child swallows, the tongue is lifted on the ramp, positioned in the upper palate where it belongs, so that with every swallow, the right position is occurred. It's interesting. I tell parents, say the letter N. Where that sound ends is where your tongue should be at rest. The majority of the parents I talk to will laugh and say, well, we have another problem. My tongue is not there. No one has ever taught us where that tongue should be. So by using these appliances, we're basically allowing and promoting and encouraging that right placement, but then making it a habitual situation so we create that proper swallow. We also have these prongs here, and you can call them whatever you want. People don't like prongs. If you want to call swords, you want to call fairy wings, whatever you want to call them. But it basically prevents the tongue from thrusting forward. And it also indicates to a patient the right time to retrieve their tongue. So they constantly continue that motion. We'll look at a child when they swallow. How do you determine an improper swallow? Put a glass of water on the operatory tray. Have a child take a glass of water. I would not, please don't tell them, let's take a look at your swallow. Just, say, would you like a glass of water? Are you thirsty? And then watch how they swallow. We should only see the muscles in the neck move with the swallow. If you see any movement of the facial, it means that the tongue is in the wrong place and the swallow is improper. So for instance, if you take a glass of water and that means that they're using their tongue and they probably have what we call a reverse swallow, or tongue in the wrong position when they try to swallow. So with these habit correctors, we're basically utilizing the body and the ability of us to swallow and putting the right mechanics in place in an appliance in order to gain the proper correction. So during the day, we swallow 2 times a minute. At night, we swallow 1 time a minute. So with these appliances, if a child would wear it at night and sleep 8-9 hours of sleep, we expect to see over 500 repetitions each and every night. So that basically encouraged such a change in the oral cavity and in the habits that occur, much more so than just doing myofunctional therapy. There's nothing wrong with using myofunctional therapy during the day, but just know the appliances will allow for this therapy to occur each and every night as long as they're wearing it. So it's an easy way to ensure that this is occurring and get the success. So there's a study that's going to be published shortly. It was over 220 children, and it basically goes through these outward symptoms and tells you what percentage of the cases you would anticipate seeing with the first 6 months of treatment with the habit corrector. So for instance, headaches. Headaches, we see that out of 220 cases, we saw 18% of the kids would have headaches. And out of those, 98% indicated improvement. The mean correction of that improvement was 94%. And you can see the percentage of cases with 100% cooperations within the first 6 months was 85% of the population. And you can go through the rest of them and see what the percentages is. So it's pretty significant, and the changes are pretty dramatic. So ADD and ADHD. Let's briefly talk about this because this is such a prevalent conversation, and unfortunately it's a condition that we see in so many kids. It is an epidemic that is going on out there. What is very interesting is when we look at ADD and ADHD, we realize that it is a condition and there is a set of criteria that is used and basically to diagnose or to provide the diagnosis of ADD and ADHD. What's interesting is that same set of criteria is the same criteria we use to evaluate sleep-related breathing disorders. Can they be misdiagnosed? Absolutely. Most recent research indicates that 85% of the children with ADD and ADHD had sleep issues. Are we trying to say we're going to eliminate ADD and ADHD? There are pediatricians out there and say that there is no such thing as ADD and ADHD. It's just different degrees of sleep issues. The research is not there yet. It might be heading that way, but it's not there yet. But what we say is if you have a child that exhibits these ADD and ADHD type behaviors, lack of focusing, that first evaluate the sleep, evaluate those underlying root causes, address that, and then take a look at where that child is. That is a really important criterion, something that we should make parents aware of before they feel like they have no other options, and maybe evaluating, because there's nothing worse than if you misdiagnose this child. So there was probably one of the largest studies done on ADD and ADHD, and it's still ongoing. And it was Karen Bonnick, and she actually looked at over 13,000 children. And she found that sleep disorder breathing increases the risk of ADD and ADHD by at least 50%. She also found that ADD and ADHD patients have little or no REM sleep, but they have delta sleep. Patients without ADD and ADHD basically enjoy both REM and delta sleep. In our study that we did of 500 children, we found that ADD and ADHD was present in 25.2% of the cases. This is a very unfortunate statistic. Long-term effects of sleep disorder breathing in regard to ADD and ADHD. We found that 50% of the children who were diagnosed with ADD and ADHD were held back 1 grade, and 30% were held back 2 grades. Well, I got news for you. If it's a sleep issue, I could hold them back 10 grades and they're still going to be sleepy. Are they going to be able to focus in class? No. Are they going to be behavioral problem? Probably. So again, misdiagnosis. Another interesting study, parents say, well, I want my kid to do well. Maybe I'll medicate them and help them focus more. Well, kids that have sleep issues, we have found that they basically reduce their IQ by 10 to 20 points. In my world, that means college or no college. If you want to put a financial dollar on what that means, do you realize each IQ point is worth $170,000 over the lifetime of a child? That's crazy. So these are important conversations to have with parents so they can understand the importance and why this is so important that we talk about. We briefly talked about craniofacial growth, how important it is to see a child to address and make more permanent changes before age 12. What's the magic number with age 12? Well, most of the craniofacial growth has completed by age 12. I mean, even look at age 2, we see that 68% of males have completed growth and 73% of females. But look at age 12, 89% male, 94% female. So it's really important to get in there and address this early on. 12 is kind of our magic number. It will basically reduce what we're able to correct and what the long-term stability is of that case at that point. The other point I want to make is look at the natural growth and development. It's in a forward and down direction, which is important to realize because we're going to show you some cases and why that's important. Looking at the lower third of the face where we see so much retrognathic growth or lack of growth, and how important it is to promote this. HealthyStart appliances are going to promote it 54% greater than in the control sample. So here, take a look at this child, and you can see how much forward growth occurred with them. So you can see here, look at the red line, you can see where that child was. You can see the deficiency, open mouth, mouth breather, circles under their eyes. Look at what it looks like 2 years. It was a little less than 2 years, and how much forward growth. We also have appliances that are going to even further promote that forward growth. Over time and through generation after generation, we're seeing even a lack of growth in the maxilla. Before, everybody talked about the mandible being lacking. Well, we even see the maxilla. And what that means is we need to have both the upper and lower jaw, that forward growth and development. And this appliance is very clever, where there is no frontal wall of it. There are 3 taps in the back, so the tongue is actually pushing against these tabs in order to create that forward movement of the upper arch. And the appliance is designed where it's going to take the lower jaw and promote that forward growth in conjunction or in unison. So here you can see initial, you can see what happened after 1 month, and here you can see currently. So we will continue promoting that growth in that child as they continue to grow. So we can start as early as age 2. Our youngest patients are actually 13 months old. So you can see how young we need to start. Class 3, kind of the same similar, except the lower dentition is basically blocking out the upper dentition, and it's preventing the maxilla to accomplish or to gain any type of growth because of that blockage. So appliance is designed very similar to the Max A, where there's no frontal wall, and these tabs are going to be used with the tongue pushing against it in order to make that forward movement of the upper arch, in order to make that jump and then continue that treatment of that case. So treatment planning, we feel very strongly that we want to make sure that we are doing every single thing for that kid. I know this is new. This is something that you probably have not had experience with. So being able to have that ability to lean on us, we will help you with identifying, addressing, and creating the proper treatment plan for that patient in a collaborative effort. So we do have diagnostic forms. We will submit them. We do have our providers who have expertise in this field. We have orthodontists on staff that will help to create a treatment plan that they can utilize with you and continue down that path. We can do progress checks as the child grows. So you always know you have that ability to reach out, talk, discuss, further evaluate each and every patient. So you're doing the most we can and getting the best results for them. So let's quickly take some cases. I know it's getting late, but these are the fun part. So let's take a look at our first patient. So you can see, here's a sleep questionnaire. You can see all the symptoms that are occurring with this child, and you can see the degree of severity. This is a severe case. You can look at the speech issues that are occurring. So let's see what this child looks like. So here is him in March of 2015. You can see excessive overbite. You can see an overjet. You can see the circles under his eyes. You can see the deficiency and growth in the lower third. Here he is in July of 2016. Overbite corrected, overjet corrected. Look at the nice arch form. Look at that child, totally different. The proportions are much more natural. We say the lower third. You should divide the face into thirds, and they should all be in proportion. And you can see how nicely that has occurred in this particular child. We can look as we're continuing, and we're just finishing guiding the teeth in, creating those same habits, and allowing that child to just prosper. Look how nice and beautiful that dentition. We always say straight teeth is basically the frosting on the cake. Our primary concern is health and well-being. Our secondary and an added benefit is beautiful straight teeth. Here's the second case. You can see again, you can see the degrees and the severity of some of these conditions, and you can see where that child is. And this is usually within a 3 to 6 month period of time. You can see the initial deep overbite, overjet, and you can see the progress that has occurred. Here's case number 3. Again, deep overbite, midlines off. You can see how that occlusion is. Here she is at finish. Beautiful finish case. You can see before and after. Here are some cases here. You can see deep overbite, the initial. You can see what it looks like at the beginning with the first appliance as they're progressing, guiding the teeth in, and you can see how that finished case looks. And this is typically primarily with nighttime wear. Here's initial, here's finish. Here's another case, initial, finish. Here's an interesting case. This particular mom was a patient that did not have any type of orthodontics, and later in life obviously had deep bites, a lot of issues, and ended up having to have surgery, which was successful. But she was hoping as a mom to prevent that in her child. She said she looked very similar to her daughter as a child, and she recognized already the problems. So you can take a look, just look visually. Dark circles, look at the way her lip posture is, deep bite, deficiency. You can see enormous deep bite. So here she is initial. Here she is during treatment. Look at the changes. I mean, her face looks completely different. Look at her dentition. Here it is. Now, this is without any appliances. This is just what we would anticipate as retention and lack of relapse. Here's another kid, snored, Bruck's, bad breath, ear infections. And you can see quite the compromised dentition. Here's about 1 year later. Here's this another case. You can see the indications. You can see what happens 3 to 6 months later. Here you see the initial. Here you see the progress as the child is developing. Here's another case, snored, bruxed, mid-treatment, now 14 years later, and stability. We offer an app that helps us monitor our patient's compliance. We did 2 very large studies. One of them was one of the largest orthodontic studies in the country of Finland. We did 3 cities in Finland, and we were able to monitor what our compliance rate was, and it actually was 94%. We also did the same type of study at Tufts University, again, 94%. I feel that we're even better now because we've introduced an app that actually is great fun for the kids. It basically monitors their compliance every morning when they wake up. It asks them, did you wear your appliance last night? Did it stay in all night? It asks the parents on a real-time basis to evaluate the sleep questionnaire. So we'll have more accurate. Every Friday, the patient is asked to take a selfie. So we do also include cheek retractors. So every Friday we have a log of what their dentition is moving to. It provides a great log for a parent. A parent can share it with friends, family, neighbors, and hopefully have your name on it as well. All of this information is also gathered and it is provided in your portal so that the 30 days that you do not see the patient, that you can actually monitor their progress and their wear. So today we've treated over 4 million cases. Just so you know, our appliances are regulated to a Class 2 medical device. We do not need to do that. We want you to be ensured that our ability to provide the safest appliance is given because your child is our child. I'm not going to do anything to your child that I would not do to my child. And this Class 2 medical device regulation basically ensures that the appliance could actually be put in the body and be safe. It is FDA cleared. There's no latex, BPA, BPS free, phthalate free, no silicone. So the safest appliance. We are very fortunate. We have so many very active doctors and providers that are screaming from the mountains what they're doing in their practices. And it is interesting. We see just 2 weeks ago, I believe, ABC in Detroit actually went in and they wanted to do a story. When they found out what the story was about, they actually sent a crew for 2 hours into a doctor's office to basically film that the case and his patients in his office. It was so successful, the producer wants to take it to the next level. So it was very outstanding. We also have doctors that are giving courses, presenting lectures to pediatricians, ENTs, pulmonologists. We had one doctor in Indianapolis at the University of Indiana give a lecture to 200 pediatricians. We're able to provide the PowerPoints for you, whatever you need to make that presentation as successful as possible. We do give parent webinars similar to what we're giving tonight for you as doctors. We can reach a couple hundred parents. One of our largest was 18,000. It occurs every Tuesday night at 8 p.m. We love to encourage our doctors to be presenters. We will solicit people within your range that would come to your practice, because we think it's critical that you educate your community. So these are all areas that we help you with. We want to provide you with the knowledge, the education, the materials to make you successful, to make you the leader in your community, and you the provider to these children for this type of treatment. So I'm going to kind of move it over here. We do have a digital course, which is critical. Education is key. And I've just kind of briefly gone over what we do in our digital series. It is a 6-part series, but it is excellent. We will go through the ABCs of everything you need to know to make you able to start treating these patients in your practice. And this digital class will also come with 2 free cases. So you're going to treat at the same time you're going through a digital class, so that you have both the hands-on experience as well as the knowledge. We do have a study forum on the Fridays that we go through this material and basically give you the information you need. So Susie, maybe you want to take it over from here. I don't know if we have any questions.
Yeah, it looks like right now there's not any questions that have come up, but you can still ask them. Use that Q&A to ask the questions. And actually, while I'm going over the digital platform, still feel free to use that Q&A and ask your questions, and we will answer them live if you ask them. So I want to show you just a little bit about the digital platform that Leslie was just talking about. So our digital class is really, I think, the most popular education series that it's really the hot topic, I think, out there. We keep hearing from doctors everywhere. And I mean, we have hundreds of doctors that attend this digital education course. And we keep hearing that this is the hot course that's out there. And I think it's because we do have that the ability for you guys to treat 2 cases simultaneously while you're taking the digital education course. And as Leslie mentioned, I see that there is a question. We'll get to it in just a sec. And as Leslie was mentioning, it is a 6-session digital education course. Great thing about this is you can take it from anywhere in the world and really at your own pace. I mean, basically what we do is on Monday morning, on January the 14th is when it starts. That Monday morning, we actually will send you a video series. You have the entire week to watch the video series. And then on Friday, we have that study forum. The study forum is recorded as well. So if you're not able to make it on, we send you everything in video format so that you have everything to watch, even if you're not able to make it on live. It includes all of your staff members as well, because we really do talk about implementing in your office, really how to talk to the parent. You know, we talk about what to look out for. We get your staff excited about what you're doing and how you're going to be helping these kids. So taking a look at the list that I have here, we already talked about the fact that it does include the 2 full cases, and really that includes everything. I mean, that app, the compliance app that Leslie was talking about, every single one of your cases is going to include that app, and it's included in these 2 cases as well. The diagnosis, all of the appliances that you need from start to finish for those 2 cases, animal cases for the kids to keep their appliances in. You'll receive a $3,000 voucher to come to one of our destination courses in 2019, because this year is pretty much getting towards the end there. But you can actually bring 3 of your staff members so that all 4 of you can come and you can attend as well. Interactive study clubs, as we mentioned, training on pediatric treatment of sleep-disordered breathing, improper facial growth and development of the dentition, screenings for sleep breathing and airway issues, increasing your patient flow. You're going to earn 18 CE credits for the digital course and then 16 more for the live course. There is a policy, as Leslie mentioned at the very beginning, that the ADA came out with, and this course actually complements that policy. And really the reality is it says that every doctor needs training. Every single doctor needs education, but it's up to you to get it. It's up to you to go out and find the education, and this course complements that policy. So we have some, as I mentioned, we have doctors from all over the world that attend our course. And so here's a couple of things that doctors are saying. Doctor in Australia said that the digital course was excellent. all at Healthy Start have really got their act together and offer resources others strive for but rarely achieve. It's well organized, passionate, supportive. Doctor in Canada, I want to thank you and your colleagues for this amazing course. I've been searching for a solid system to help my patients, and this is by far the best, most organized, comprehensive course, that I've ever taken. And a doctor in Colorado, I have really enjoyed the course. We've identified quite a few patients that will benefit from Healthy Start. My business partner's 4-year-old is in the habit corrector because he's had swallowing problems, and we've already seen great improvement in his eating. We already have 3 more patients who are starting next week. Can't wait to see their progress. Cool thing about this doctor is she was only in week 3. So 3 weeks in, she already had patients lining up at her door. And the reason for that is because when parents start seeing the system work, it's amazing. When suddenly you see your child sleeping better, they're not having headaches anymore. The bedwetting is not present any longer. They feel better. They're doing better in school. It's amazing. It truly is life-changing, and it changes the life, not just of that child, but of that entire family. Parents are going to talk about it, and they're going to tell other parents, and pretty soon the word's going to be out that how you're helping these kids in your office, and they're going to be lining up your door, and that happens all the time. And then ADA actually took our course, and they said that the course was ingenious. So it's pretty high praise, I think, especially from ADA, which I love. There's a lot of ways you can get involved. Of course, you can give us a call. You can call 844-KID-HEALTHY, and we can help you get set up and register for the course. You can actually register online, and we are doing a promotion. It's a webinar promotion, just like an event promotion, but we're doing a webinar promotion, $300 off of the course. So the course is an investment of $3,400, and which is amazing because you're going to get those 2 free cases. You're going to get that $3,000 voucher to come to our destination course. It includes every single one of your staff members, which is huge. And so basically it's return on investment immediately because you have those 2 cases. Anyway, it's an awesome deal, but we're giving you $300 off anyway. And all you have to do is visit www.openairwaydentistry.com. There's a button that says register now. Click that button, and there is an area for you to put in that promo code, and you just type in airway, and it'll take that $300 off. My contact information is slafredo@thehealthystart.com. So if you have any questions, or if you want me to clarify anything for you in reference to the course or whatever, if you have additional questions for Leslie, you can email me and we will make sure that your questions get answered. And I have on here, now's the time, and together we can make a difference, because now really is the time. I mean, once you have realized this information and you understand that there's so many kids that are affected. As a matter of fact, the national statistics said over 40 million kids are affected with sleep-related breathing disorders. It's amazing. You'll start seeing every child that comes into your office, you're gonna start noticing a difference. And so now's the time. We have to, early intervention is key. So and together we truly can make a difference, and we're making a difference with so many doctors around the world, and we'd love to make a difference with you as well. So anyway, I noticed that there is a question, so let me click up here and see. Okay, so I'm interested in taking the course. I would love to educate parents and give presentations. Yes, and we will actually supply you with a parent presentation as well, so that way you can not only present to your parents, but also we can get you involved in parent presentations, kind of like what Leslie was talking about. On Tuesday evenings, we'll let you be the star. I'll even promote in your area. I'll promote on your social media. We'll get as many parents involved as we can, so we can really spread the word and let the community know what you're doing. And it's just it's really a we love working with our doctors, and we love to help you spread the word. We want you to be successful, and we want you to be successful so you can help as many kids as possible, but also so it's a great experience for your practice as well. So yes, Dr. Reddy, I'll get in touch with you, and you can either go online and register on openairwaydentistry.com and sign up now, or you can send me an email if you'd like, and I can help you get registered that way. So whichever way you'd like to do that. Leslie, is there anything that you'd like to add?
I'm just hopeful that we were able to provide you with enough information. I feel that it's always a great overview, and I would just encourage you to sign up, get started today. You know, we always make New Year's resolutions, end of the year. This is probably one of the best and most meaningful decisions that you could make. So I encourage every single doctor, please, at least be educated in this field so that your current patients, you're identifying, alerting them, providing that guidance for a parent so that we can make a difference. We need to end this epidemic, and we need to make give kids the ability to reach their full potential. I always say eliminate the barriers that prevent them from being the successful people they should be, and allow them to live the happiest and healthiest lives available. So saying that, happy Thursday. Tomorrow's Friday. I hope you all have a great weekend. Happy holidays. Best wishes for the new year. And hopefully you become a part of our Healthy Start family and we move in the direction of education. So thank you so much for spending the evening. Susie, thank you as always. It was a great evening.
Yeah, thank you so much. I appreciate your time. I put up this new slide, how do I get my CE credits, just so you know, they will be emailed to you. So, but if you have any questions, or you can always, of course, reach out to our office, contact at thehealthystart.com or 844-KID-HEALTHY, but give us a couple of days and we will actually get your CE credit right out to you. Thank you so, so much for being with us, for spending the evening with us. Leslie, as always, you are amazing. Thank you for the information. And if any of you guys, like I said, have any questions, please do not hesitate to reach out. slafredo at thehealthystart.com. I can answer your questions. I can get them forwarded to Leslie if you have a medical question, or if you have questions about the course, I can get those answered for you as well. Have a wonderful night. Have a wonderful almost weekend. Yeah. And thank you again for joining us.
Take care. Good night, everyone.